Welcome to PCR London Valves 2024. My name's Dan Blackman. I'm an interventional cardiologist from Leeds in the UK, and I'm here with Martine Gilard from Brest in France. Martine, it's great to be with you. So we're here to talk today about considerations specifically when undertaking TAVI in women. And Martine, I guess the first thing that we know is that women are underrepresented. They present less frequently than men with aortic stenosis. They present later and they're undertreated. You know, our own UK data showed women were 45% less likely to have TAVI or surgical AVR than men with a diagnosis. So we've got some issues here. And we need to recognise, I think, as a first step, the differences between men and women. So maybe you can tell us, in terms of the anatomy, what differences we see and we understand now between men and women with aortic stenosis.
Yes, I think the heart of women is different from the heart of men. For TAVI, you have to know that the anatomy is very different because it's smaller. Everything is smaller. The annulus is smaller. The sinus is smaller, the coronary height is smaller. So it's very, very important when you plan a TAVI in a woman to take this in consideration in order to have a good outcome.
Yeah, really important points. And also in terms of the valve itself, you know, maybe one of the reasons that patients are less well diagnosed is because there's less calcification often on the valve, and the anatomy is dominated by fibrosis.
Yes.
And that can go under-recognised and also affects the way we treat patients. And then we see different remodelling patterns, as we know, more concentric left ventricular hypertrophy, more paradoxical low flow, low gradient. So these are kind of things that we clinicians need to recognise in women in order not to miss severe AS. So when we think about those anatomical differences and look at the imaging, can you tell us about how we need to think about women more specifically with our imaging of aortic stenosis?
Yes, and this difference in calcification is very, very important because people are used to have a huge calcification when the aortic stenosis is very tight. However, in women, there is more fibrosis, and I think this is also important to understand because the outcome are better in a woman than men, probably also due to this difference in the amount of calcification. There is less calcification in women, so it's difficult to diagnose aortic stenosis because there is less calcification. So it's why the rate of CT is different from between men and women. And also this less calcification explains probably one of these explanations of the better outcome for TAVI in women compared to men.
Yeah, so as you said, we have different scores, thresholds for diagnosing severe AS. It's 1,200 with women, 2,000 with men. But what about the echocardiographic parameters? I mean, they're the same for men and women. Is that right? Or do we need to have different measures?
As you say, it is very important to understand that there is the remodeling of the LV is different from for women because it's more concentric than in men. And also the paradoxal low gradient, low flow. It's very important to understand that. So perhaps we need different criteria for women in order to say, okay, this woman has a tight aortic stenosis because the criteria are not the same. And perhaps, for example, the mean gradient for man is, we said for all the population, it's 40, but perhaps it's 35 for women. So I think it's important to understand this difference in anatomy, in imaging, in order to understand that we need to be careful with women, and perhaps it's why also that women are under-treated by TAVI because we think that this woman has not so tight stenosis or severe stenosis than men.
And if we bring in those different thresholds, that could really go a long way to improving diagnosis and increasing treatment in women.
Exactly.
So let's come on to the TAVI procedure. I mean, I think you discussed probably the key challenge, which is small anatomy.
Yes.
How does that affect the way we might treat the patient? Valve choice, I mean, we've seen the SMART trial showing perhaps better hemodynamic outcomes with self-expanding than balloon-expanded valves. Is that a way we should be moving, or do we need more data to understand that better?
I think we need more data because we have two different trials with different results. So I think we need more data. And another complication, which is more important in women due to the smaller anatomy, is the vascular complication. And for women, there is more vascular complication. So the choice of the valve depends of everything. So it depends of the access, it depends of the annulus, But I think for each patient, you can choose one type of valve, and it's not necessarily this type of valve when the annulus is small and this type of valve. I think there is too much criteria in order to guide us for the choice of the valve.
So one factor in valve choice, but there are many others that you need to bear in mind.
Exactly.
Martine, I think we've had a great discussion. I mean, we know that women are underrepresented. They present less, they present late. We need to get better. Maybe that's going to mean a change in the diagnostic thresholds, both for echo, as we've seen for CT. And then it's important, and I think many physicians will be surprised to see that TAVI outcomes are actually better in women than they are in men, possibly because there's less calcification. So these patients have a lot to gain from having TAVI, and we're going to learn a little bit more over the years to come about whether the hemodynamics of a self-expanding valve set against the advantages for coronary access and retreatment of a short frame valve, and which of those will win out if either in the end. So thanks very much for joining me for this important discussion, and that's goodbye from us from London.